Welcome back to another refresher video. This one is on diabetes. NCCP calls for an hour. We'll get there, basically. We're going to talk about what is diabetes. We're going to talk about the two types, maybe three types. And we're going to talk about signs and symptoms. We're going to talk about hypoglycemia, hyperglycemia, the treatments for it now, as well as some of the awful things we've done in the past. In the past, I've had some really good classes on this. I had a diabetic educator at Exeter Hospital who did a bunch of courses for me when I was their educator. And so I learned a lot of different things from her, and it made me aware of what we've been doing wrong. And sometimes doing the right thing is not the easiest. I mean, it's that way in life, generally speaking. But so we're going to start diving into this. Some of this will be me talking, some will be as I write on the board. So here we go. I arrange my notes. I'm going to keep myself on track. So first off, diabetes. Where's insulin made? Right? It's made in the pancreas. So insulin is made by our body in order to allow the cell to take in glucose, right? If you think about our cells are these little simple structures with a cellular wall, and that cell wall is what we call semi-permeable. Some things get into it and out of it with no problems. The glucose molecule is too big though, so it needs a gatekeeper. The cell wall needs some assistant coaches, right? Belichick can't do everything. He can't do everything. He needs some help. And so the cell wall needs some help with different things. And glucose is one of them. So glucose is floating around and it needs insulin to get through that cell wall. Without insulin, that's type 1 diabetes. So the pancreas can't make insulin, type 1 diabetic. One of the kind of phrases for that is juvenile diabetes, because in the past it was kind of thought and assumed and taught that if you were type 1 diabetic, you were diagnosed when you were 3, 4, 5, 6, 8. Okay, but now juvenile diabetes, type 1 diabetes, does come as a child. It also is diagnosed as a teen and also as a young adult. We're seeing a lot more, early 20-somethings that are coming into the ERs, and they're in DKA. That's type 1 diabetic. We'll go into the difference between DKA, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome, which is a type 2 disease. But when they come in and they're acidotic, it's DKA, they're type 1. And so we are seeing that a lot more in our younger people. So our type 1s need insulin. They need injected insulin in order to get the glucose across that cell wall. Those of us who are not diabetic or who are type 2 diabetic have plenty of insulin being made by our pancreas. So our type 1s don't have the insulin. Non-diabetics have insulin, have no issues with it. Our type 2 diabetics have insulin, but the insulin needs yet another assistant coach to help, because that cell wall is resistant to the insulin. So the type 2s end up, if they need medications, they end up on typically oral stuff, glucophage, metformin. Sometimes they end up on injectable insulins as well. So that's the job of the pancreas, is to make insulin. And when it doesn't do it, we don't absorb glucose into our system. So, type 1, no insulin. Type 2, we make insulin, but we're resistant to it. And the third type of diabetes is gestational. So, pregnant women sometimes develop diabetes. The stress of the pregnancy that the body's under while creating another human, feeding another human, and fighting off their own disease processes at the time. So, they can be oral diabetics, like you would think of as a type 2, or they can end up on insulin, like you'd think about for type 1. And the majority of these folks, though, once their pregnancy is over, they've delivered the baby, they go back to being what they were beforehand. So, type 1, type 2, gestational. Now, how do we diagnose diabetes? Excuse me. So if you have regular checkups with your doctor, you have regular checkups whether you're a child, a teen, an adult, or an older adult, then they typically do blood work in relationship to it. One of the things they check is, and these are fasting lab draws, so nothing to eat after midnight, right? And so come 7 a.m., they're looking for what your glucose is. And so the definition now of diabetes, with a fasting glucose, a fasting plasma glucose is less than 100 is normal. 101 to 125 is pre-diabetic, and anything over 125, so 126 and above, is diabetes. The other thing they will check is called an A1C. And an A1C is an average over time of your glucose. It seems like voodoo to me, but so anything less than 5.7, is normal. Between 5.7 and 6.5 is considered pre-diabetic, and anything over 6.5 is diabetic. So there are charts that you can Google online, and it will tell you if your fasting glucose is 8, then if your A1C, fasting A1C is 8, then your fasting blood sugar is averaging, I don't know, 180, 190, whatever it is. I don't remember the numbers off the top of my head, but any number you could imagine for an A1C, they've got it on a chart. The American Diabetes Association is a pretty good resource for all this. Now, if you are having your appointments and you're having lab work done, that's easy. Before you get sick, they figure, hey, you're diabetic. You know, you're an older adult, you're in your 40s, 50s, 60s, and you go to your doctor every year, and every year your A1C is creeping up a little bit, a little bit, a little bit. When it gets into that pre-diabetic area, your providers will start to do things for you. Recommend diet and exercise, for example. Because if you lose weight, you lower your risk for diabetes. In fact, in type 2 diabetes, you can lower your risk of type 2 diabetes 58% by losing 7% of your body weight, which means if you're a 200-pound pre-diabetic, you drop 15 pounds, you drop your risk of diabetes by 58%. That's pretty amazing. And on top of that, though, and with that, exercise 30 minutes a day for 5 days a week. So drop 15 pounds and walk 5 times a week for half an hour. And you probably won't have any of the issues that people develop with type 2 diabetes. So what are the risks of diabetes long term? Why do we want to prevent type 2 diabetes? Why do we want to keep good control of type 1 or type 2 diabetes? Diabetes is first and foremost a vascular disease. So we know that diabetics have bad blood flow. They're at more risk for wounds that don't heal, sores on their feet, right? Feet are the furthest part away from the heart. You need good circulation to perfuse the tissues in your feet. If you don't have good perfusion, you end up with these problems. So what do I mean by vascular? So we have a blood vessel. Now beside these blood vessels, we have veins, arteries, and nerves. So let's call that a nerve right there. Kind of thick line so you can see it a little bit better. In our bloodstream, if we're diabetic and our sugars are high, we have an increase in blood sugar because that glucose is not getting into the cell and is not being used up by the cell. So as we start to develop hyperglycemia, 2, 4, 6, 8, 10, 12, 14. So let's say there's 16 glucoses. So let's say our sugars are running 160. 160 is not enough to make us symptomatic, but it is certainly enough over a course of time to cause cardiovascular damage and to cause nerve damage. Hyperglycemia, asymptomatic hyperglycemia, even at fairly low levels, over a course of a couple of decades, will cut years off the end of your life. Okay, so you've got all these glucoses in your vasculature. If you've ever eaten a caramel apple or a candy apple, oh man, I love caramel apples. What that is you've got an apple with a sheet of sugar on top of it, and you put it in the oven, and you're caramelizing that sugar down around that apple until it folds completely around it and sticks to it, right? And now it's this tasty, high glucose treat. Sugar will caramelize at 98 degrees. That's a problem because that's our body temperature, right? 98.7 is textbook body temperature. So the higher or the extra glucose that's in your bloodstream will actually caramelize around the walls of your bloodstream and will actually soak out through your bloodstream and caramelize the nerves that run next to it. So now we have damaged blood vessels and we have damaged nerves. That leads us to our neuropathy, our numbness, tingling, and pain in our feet and lower legs. It leads to our inability to perfuse the cells and tissues in our feet and lower legs. So we develop sores. We don't know we've developed these sore spots because we've damaged the nerves, and so they get worse. And suddenly we find we have this horrific sore on our foot, and it's not healing, and it gets infected. Diabetics are at risk for perfusion, and they're also at risk for fighting infection. Our kidneys become damaged because the blood vessels in our kidneys become damaged. Okay, we have the same issue with our eyes. So the optic nerves and the blood vessels in our eyes become damaged. We can develop cataracts and we can become blind. Skin, doesn't matter where. I've been saying feet and lower legs because that's very, very typical. But it can be skin anywhere, and you develop these horrific infections. I remember a patient in the ER who knew he had a couple of sores on his feet, and he was afraid to look at them. And so finally, they didn't hurt. So finally one day he came to the ER, and he had not taken his shoes or socks off in 3 weeks. Because denial means it won't happen, right? Denial ain't just a river in Egypt. So at the time, my wife-to-be was the nurse, and she went into that far room and pulled his socks off, and 2 of his toes fell out on the floor. You couldn't feel it. Now, mind you, we could smell it. The smell hit the nursing station just before my wife came running out of that room gagging, because he had gangrene, and I mean toes rotted and fell off. I couldn't feel it. I've taken care of diabetics who have stubbed their toes on table legs, broken toes, and didn't know it. They were in their socks, right? Stubbed their toes. They put their shoes on that night or the next day. Whenever they take their shoes off next and take their socks off, they're like, "Oh my, look at that! My toes are broken. My toes look funny. Yeah, they're broken." Okay, so that's a big problem. Bones and joints become damaged, and teeth and gums. Teeth rot, teeth fall out, gums rot. They get gingivitis, teeth fall out. Okay, so these are all things. The cardiovascular side of it, they have a lot more, because the vessels are damaged. They have worse cardiovascular disease. They have higher incidences of MIs and strokes and everything you can think about, okay? So that's why we want to keep diabetics under control. And if you are pre-diabetic, why we want you to not become diabetic, okay? So we've already said between fasting glucoses and fasting A1Cs, if you're getting checkups, then we know you're diabetic. Probably the most common way is a patient either presents to their physician's office or to the ER with a set of symptoms. Very common symptoms for both are extreme thirst, drinking gallons of water a day, peeing their brains out, always hungry, and they're losing weight or can't gain weight, which makes no sense to them because they're always eating, because they're always hungry. So why do we have hunger? Well, the cells are hungry. The cells are not getting the glucose they need for their day-to-day activities, right? I mean, different organelles within the cell have things they have to do. They have to produce energy, right? They have to break down glucose into ATP and break down ATP to give off energy, right? They have to get rid of waste. And so without the glucose, it gets harder to do that. So the cells say, hey, we're hungry, send us some glucose. And the brain goes, okay, well, if I need glucose, obviously I'm hungry. Damn, I'm hungry. And you eat. And I'm still hungry, so I eat. And I'm still hungry, and I eat. Why thirst? Well, the more glucose you have in your bloodstream, the more the body says, oh, that's not good, I need to dilute it, right? So if you take a water bottle, a 24-ounce water bottle, and you put 8 ounces of water in it, and you put 2 teaspoons of sugar, it's going to be pretty sweet. If you add an extra 8 ounces of water, you've now diluted that 2 teaspoons into the equivalent of 1 per 8 ounce. Instead of 2 per 8 ounces, you've got 1 per 8 ounce, and it doesn't taste as sweet. If you then add this third 8 ounces to it, you dilute it even further. There is less sugar per deciliter, okay? So the body will tell you you're thirsty. Oh God, I'm thirsty. Trying to dilute that glucose. Now your kidneys are involved in fluid balance. And your kidneys say, holy crap, look at all that water coming down the pipes. No pun intended. I got to get rid of some of it. So you start to pee more. Here's the other problem. Besides your body saying, hey, I need water to dilute my glucose, it will pull water into the bloodstream from the intracellular spaces. So the space between the cells, okay, it will pull fluid from that space, interstitial space, into the bloodstream also. To make up that loss of fluid, the body will pull fluid from the cells themselves, right? It's called osmosis, from an area of high concentration to low. So the body says that the vessels need fluid, well, high to low. Backfill that high to low from the cells into the interstitial space. So now the cells are dehydrated, okay? So now the body also says, well, crap, I also need to hydrate myself. So you drink more and more and more. And the kidneys are peeing out more and more and more and more. And you're never able to catch up to this osmolar, hyperosmolar dehydration, right? So osmosis. Hyperosmolar is like you got regular osmosis from high to low. Hyperosmolar is way up here, out of control. Your cells are dying because they don't have the fluid. So I'm thirsty, I'm thirsty, I'm thirsty, I'm thirsty. I'm pulling fluid, I'm drinking. Kidneys are working overtime, and we're not catching up. So, they bring their 8-year-old into the pediatrician and say, hey, he's always eating, and he's not gaining weight, and he drinks gallons of water a day. And I just figured he was peeing all the time because of all the water he drinks. Well, old school. So, like, not that long ago, really, up into like 50s and 60s. I mean, I know physicians who were taught to do this. They would take the urine cup, dip a finger in it, and if the urine tasted sweet, they're spilling glucose, they're diabetic. That's pretty gross. I watched an ER doc I know who had been taught that back in the 60s or 70s. Had a glove on, dipped his middle finger into the urine. The nurse said, hey, do you want me to send this? He dipped his middle finger in, put his index finger in his mouth, which I caught. They didn't. And he goes, no, there's no glucose, we're all set. And I thought I was going to wet myself. I was laughing so hard. But it's an old school thing. And I have people who refuse to believe it. They tell me I'm full of shit, but that's the way they used to do it. Then we developed these little dipsticks, and you could just dip it in the office. You could dip it in the ER and go, oh, yep, spilling glucose. Okay? And now, of course, you can send it to the lab, and they can tell you exactly how much glucose is in there. Because with all this hunger, thirst, and urination, you will spill some glucose. You will flush some of that out of your system. Okay, and it will go into your urine, and you will spill some. Okay, so 3 P's: polyuria, polydipsia for for thirst, and the third poly is hunger, and I don't remember that one. I blanked out. Sorry. Anyway, so those are the 3 key diagnostic symptoms for hyperglycemia. They get worse, though. Okay. Hopefully we catch it at that point. So the other thing is that as this gets worse and glucose climbs, we have 2 different types of hyperglycemic emergencies. Okay, so let's go to type 1. We're going to compare these side to side. So we've got the whole water thing, both sides. We've got thirst, both sides. We've got urination, both sides, okay? Now, as this starts to get worse, we start to see a few other things, which in some cases are fairly similar also. We have dehydration. Now, how can we tell dehydration in these patients? Dry mucous membranes. You pull their lip down and you look inside their lip, and instead of being a nice pink moist tissue, it's dry. It looks dry. They're not crying. You know, these little kids aren't, when they're crying because their belly hurts, there's no pain, okay? I mean, there's no tears when they cry. The other thing is skin tenting. So if you look at the skin and you pinch up a little fold of skin and let go, it should go back to normal, nice and flat. But if it sticks up for a second or two, that's because the cells that make up this tissue that make up the skin, the organ, skin, are dehydrated. And you'll have skin tenting, okay? So you can look at that in these folks. Abdominal pain is fairly common in both sides as well. Now, we have another symptom. Fruity odor. Fruity odor is caused by the spilling of ketones into the bloodstream. Ketones. And this is type 1 only. Okay, we do not have that with our type 2 patients. Then we start to get into our altered mental status, loss of consciousness. That goes to both sides. Okay, which of course can lead to coma. All right, unresponsive coma, not waking up. That can be on both sides. However, so unresponsive tends to be more the type 2s at the height of their hyperglycemic event. Okay. Respiratory rate. If you remember the term Kussmaul respirations, fast, deep, and nice and regular rate, nice and regular rhythm, but fast and deep. So Kussmauls. That is type 1 only. Okay. So when we walk into, well, first let me back up a little bit. Our hypoglycemic patients look a lot like this also. I mean, they have the altered mental status. They can be unresponsive. They can certainly be dehydrated from other causes. Okay? But those are the big things with our hypoglycemics. Okay? So when we look at our hyperglycemic, how can you tell? Let's say they can't give you a history. How can you tell type 1, type 2? It's really not all that important to us in the field. We're going to treat them the same way. But this respiratory rate, this fruity odor, are the two big things. That is the hallmark of diabetic ketoacidosis. All right, so let's look at what I mean by that and why we get that. Okay, so remember, these folks, no insulin. These folks have insulin. Okay? So if you have no insulin in your bloodstream and you don't take your insulin, your body needs to find other avenues of nutrition. So it will start to break down muscle and fat in order to give you some form of nutrition. Now, when we look at the cell wall is used to what we call aerobic metabolism. So aerobic metabolism is when your body uses glucose and oxygen to create adenotriphosphate, ATPs. And I believe the number is 38. So you get 38 ATPs. When your body breaks down those 38 ATPs, when your cell organelles break it down, it gives off energy. It also gives off a waste product. With aerobic metabolism, that waste product is heat, carbon dioxide, and water. Those are all great things. Our body needs them. It's how we warm ourselves up. If you are cold and you start to shiver, your body has cranked up its aerobic metabolism by moving the muscles, which makes you break down more ATPs to create more energy to move those muscles, which releases heat. And that's how you warm up. Right? You know you release water through your respiratory system because if you have a mask on, and we know about masks now, right? You fog up your glasses. Or if you have a diving mask on or an SCBA on, you fog up your glasses. All right? You fog that mask up. So those are good byproducts. Perfect.